critically low, not borderline, not low normal, not something to revisit at your next annual check. Critically low, the level at which biological systems that depend on B12 are not simply underperforming, but are being actively and progressively destroyed. The level at which the damage being done today, if the deficiency continues uncorrected, is the damage you will be living with permanently in 6 months' time. The word critically matters here because it describes a threshold. Below that threshold, the body compensates, it draws on reserves. It produces early signals that something is wrong. The subtle fatigue, the mild tingling, the fractionally slowed thinking that most people absorb into their baseline and explain away. Above that threshold, when the reserves are exhausted and the compensatory mechanisms have failed, the body stops sending gentle signals and starts showing structural consequences. And the difference between a gentle signal and a structural consequence is the difference between a problem you correct and a problem you manage for the rest of your life. The 8 symptoms in this video sit above that threshold. They are not warning signs in the precautionary sense. They are clinical indicators that significant biological damage is either already underway or rapidly approaching. Each one has a specific mechanism. Each one represents a body system under severe enough stress that the underlying cause is not something to monitor, it is something to investigate and treat urgently. I want to be honest with you at the outset about why this video exists. Because these 8 symptoms are routinely missed, not in rare or unusual clinical circumstances, but in routine medical encounters, GP appointments, pharmacy consultations, specialist reviews where the symptom gets addressed and the cause does not, where the pain gets treated but not the nerve, where the mood gets medicated but not the methylation cycle, where the memory loss gets worked up as dementia rather than as a correctable deficiency that has been running unchecked for 3 years. If these symptoms are present in you, in someone you care for, the question this video will equip you to ask is simple. Has anyone checked the B12? Hi, I am Dr. Alex. I am an emergency medicine doctor, and I have spent nearly 10 years in the AANEE encountering B12 deficiency at the stage where gentle signals have been replaced by clinical emergencies, where the balance has failed completely and the person is falling, where the hemoglobin has dropped to a level that strains a heart that was not built for that kind of chronic compensatory demand, where the cognitive decline has been attributed to a neurodegenerative disease that will never improve when the real driver is a nutritional deficiency that, caught earlier, was entirely correctable. I do not build this channel to alarm people. I build it to give people the interpretive framework that the medical system does not always have time to provide. The framework that turns a symptom from something you adapt to into something you act on. And at the level of severity represented by the 8 symptoms in this video, acting is not optional. It is the only reasonable clinical response. Before I take you through the 8, I need to give you the biological foundation, not in abstract terms, but in the mechanistic terms that make each symptom comprehensible and urgent. Because the urgency is not rhetorical, it is biological. And once you understand the biology, the urgency becomes self-evident. I promise to keep creating the most useful and well-grounded videos I can, built on science and clinical experience designed to help you live longer and avoid the diseases I see every single day. All I ask is that you give this fairly new channel a chance and hit the subscribe button. If you reached the end of this video and did not find it genuinely valuable, feel free to unsubscribe, no hard feelings at all. But if you give me your time, I will give you everything I have learned for more than a decade in medicine. Please subscribe and let us get into it. When B12 falls to a critically low level, the damage it causes is not the output of one system failing. It is the simultaneous deterioration of 3 systems that have been drawing on the same depleted resource for months or years, and that have finally exhausted the compensatory mechanisms that were masking the problem. Understanding those 3 systems and what happens to each one when B12 reaches critical depletion is what makes the 8 symptoms in this video legible as a coherent clinical picture rather than a collection of unrelated complaints. The first system is the blood, specifically the production of red blood cells in the bone marrow. Red blood cell production is one of the most biologically demanding processes the human body performs. The bone marrow must generate 2 million new red cells every second, and each cell requires accurate DNA replication to form properly. That DNA replication depends on folate, but folate cannot be activated or recycled without B12. When B12 falls to a critical level, folate becomes trapped in an unusable form through a mechanism called the methyl trap. DNA synthesis in the bone marrow stalls. Red cell precursors enlarge without dividing. They are released into circulation as megaloblasts, oversized, structurally defective cells that carry less hemoglobin per unit volume, bind oxygen less efficiently, and die after a fraction of the lifespan of a normal red cell. The result is megaloblastic anemia, not the mild pre-anemic state of early deficiency, but a significant, clinically measurable reduction in the blood's oxygen-carrying capacity. Hemoglobin may fall to levels that, in acute blood loss, would prompt transfusion. And because the process has been slow and the body has adapted incrementally, many patients arrive at a hemoglobin of 60 or 70 grams per litre, still ambulatory, carrying within them a cardiovascular demand that is silently straining their heart, their kidneys, and every oxygen-dependent organ in their body. Now add the second system, the nervous system. Myelin, the insulating sheath around every nerve fibre in the body, is maintained through methylation reactions that depend on B12 as an irreplaceable cofactor. B12 enables the conversion of homocysteine to methionine, and methionine feeds the production of S-adenosyl methionine, the methyl donor that drives myelin synthesis and repair. When B12 is critically low, this methylation cycle has been running below capacity for long enough that structural myelin damage has accumulated. This is not the subclinical myelin stress of early deficiency, the hairline cracks in the maintenance budget. This is the structural failure that produces measurable nerve damage on electrophysiological testing. Peripheral nerves have been demyelinating for months, and in the most severe presentations, the demyelination has moved centrally into the spinal cord, involving the dorsal and lateral columns that carry sensory and motor function between brain and limbs. Simultaneously, a second toxic mechanism is operating inside the nervous system. Without adequate B12, methylmalonic acid accumulates and becomes directly toxic to neurons, disrupting mitochondrial function inside nerve cells, impairing the synthesis of structural fatty acids that make up myelin, and accelerating the degradation that the methylation failure has already set in motion. Research published in the journal Neurology has confirmed that methylmalonic acid accumulation produces measurable neuronal damage at concentrations that correlate directly with the severity of neurological symptoms. This is not a marker of deficiency, it is a driver of damage. The third system is the brain's metabolic environment, homocysteine, which accumulates whenever the B12-dependent methylation cycle stalls, is neurotoxic in the specific sense that it damages neurons, generates oxidative stress in brain tissue, promotes neuroinflammation, and impairs the function of small blood vessels supplying the brain. At critical B12 levels, homocysteine has typically been elevated for a sustained period long enough to produce measurable changes in brain structure. Research published in Neurobiology of Aging has demonstrated that sustained elevated homocysteine is associated with accelerated hippocampal atrophy, shrinkage of the brain's primary memory structure, and with measurable cortical thinning in the prefrontal areas that govern reasoning, planning, and emotional regulation. These are structural changes, they are visible on imaging, and they produce cognitive and psychiatric symptoms that, at the critical level, can be severe enough to be mistaken for primary neurodegenerative disease. The absorption failure that allows B12 to reach critical levels operates through the same pathway it does at every earlier stage, the loss of intrinsic factor production, the interference from medications like proton pump inhibitors and metformin, the immune destruction of parietal cells in pernicious anemia. But by the time critical depletion has been reached, the liver reserves that previously masked the problem have been exhausted. The person has been running on borrowed biochemistry for long enough that the loan has come due in full. And the systems that have been most stressed by the depletion are the ones that show the most dramatic clinical consequences. That is the biology at the critical level. Now let us talk about what it looks like when you are in the room with it. Just very briefly, if this is valuable, please consider subscribing. It helps this channel reach more people who genuinely need this information when they need it most. I want to frame these 8 symptoms with a clinical observation before I describe each one. In my experience, what patients with critically low B12 most often say when asked how long they have been experiencing these symptoms is longer than I realized. They have been incorporating the changes into their understanding of themselves, their new energy level, their new cognitive baseline, their new relationship with their balance and their limbs for so long that they have lost the reference point of who they were before. The deficiency has redefined their normal, and it is only when they are shown what a different normal looks like on the other side of correction that the full scale of what they were carrying becomes apparent. The first symptom is a fatigue that is no longer fatigue in the ordinary sense. It is exhaustion that has become the dominant feature of the person's daily existence. Not a tiredness that varies with sleep or rest, a profound, unrelenting depletion that is present from the moment of waking that makes the simplest tasks require deliberate effort that has progressively narrowed the person's world as they reduce activity to manage a threshold they can no longer exceed. The mechanism is severe megaloblastic anemia, a hemoglobin reduced far enough below normal that the body's tissues are operating under a sustained oxygen deficit. Every organ is working harder to extract adequate oxygen from blood that cannot supply it efficiently. The heart is compensating with an elevated resting heart rate. The muscles are fatiguing faster because aerobic energy production is impaired at the cellular level. The brain is slowing because it is the most oxygen-dependent organ in the body, and the oxygen is not arriving at the volume it requires. This is not tiredness. It is a body running on a resource that has become critically scarce. And it will not improve with rest, with nutrition, with lifestyle change, or with anything except correction of the deficiency that is causing it. The second symptom is a pallor and yellowish tinge that is visible to others, not the subtle paleness and faint yellow hue of moderate deficiency, but a complexion that has become noticeably, obviously abnormal. The skin has a grey-yellow quality, the whites of the eyes are yellow, clinically visible jaundice. Family members notice and comment. This combination, pallor from severely reduced functional hemoglobin and jaundice from the bilirubin released as megaloblasts break down at a rate the liver cannot process, is a hematological signal that is visible from across the room. I have had patients described to me by their families as having looked yellow for months before anyone investigated the cause. At the critical level, this degree of visible jaundice combined with pallor is a presentation that warrants same-day blood work, not a planned outpatient appointment. The third symptom is a resting heart rate that is noticeably elevated, or palpitations, and breathlessness that are present not just during exertion, but at rest, or with the most minimal activity, walking from one room to another, rising from a chair, speaking for an extended period. At this level of anemia, the cardiovascular compensation is no longer subtle. The heart is working substantially harder than it should at rest to maintain adequate oxygen delivery to vital organs. In patients with pre-existing cardiac disease and in older patients, this is a substantial proportion. The added hemodynamic burden of severe anemia can precipitate frank cardiac decompensation. Fluid accumulates, breathlessness at rest appears, leg edema develops. The clinical picture resembles heart failure, and in some of these patients, it is heart failure secondary to the anemia precipitated by the sustained compensatory demand on a heart that had limited reserve. I have seen patients admitted to the cardiac unit for decompensated heart failure whose primary driver was a hemoglobin of 65 secondary to untreated megaloblastic anemia. When the anemia was corrected, the cardiac picture resolved. The critical B12 level was the cardiac event. The fourth symptom is a significant and progressive deterioration in balanced walking, one that has moved beyond the instability of moderate deficiency into a functional impairment that is affecting safety. Falling without clear mechanical cause, walking with a wide-based uncertain gait, inability to walk in a straight line, requiring support from walls, furniture, or another person to navigate safely. The mechanism at this severity level is spinal cord involvement. The dorsal columns, which carry proprioceptive and vibration sense from the limbs to the brain, have been demyelinated to a degree that their function is substantially impaired. The brain has lost accurate positional information about the lower limbs. The person has been visually compensating for the proprioceptive deficit, but that compensation is no longer sufficient. Clinical examination at this stage will show absent vibration sense at the ankle and knee, profoundly impaired proprioception, and a strongly positive Romberg test, the person sways substantially or falls when standing with feet together and eyes closed. These are the examination findings of posterior spinal cord disease. In a patient with B12 risk factors, they are the examination findings of subacute combined degeneration at an advanced stage. The fifth symptom is a severe and widespread sensory disturbance, not the intermittent mild tingling of early deficiency, but a persistent, often painful or deeply uncomfortable, abnormal sensation affecting large areas of the hands, feet and legs simultaneously. People describe it as a constant burning, a deep aching in the bones of the feet and legs, an extreme sensitivity of the skin surface, where even the light pressure of bed sheets against the feet at night is intolerable. This is peripheral neuropathy at an advanced stage, multiple peripheral nerve fibers significantly demyelinated, producing both the loss of normal sensation and the paradoxical generation of painful or uncomfortable sensory signals in areas where sensation should be absent or reduced. Research published in the Journal of Neurology has documented that the severity and distribution of peripheral sensory symptoms at the time of diagnosis is directly correlated with the duration of deficiency. The wider and more painful the sensory disturbance, the longer the process has been running. At this level, sensory recovery with treatment is often incomplete, particularly in the feet, where the longest peripheral nerves are most severely affected. The sixth symptom is a significant cognitive impairment, specifically a memory loss and a confusion that has crossed the threshold from affecting quality of life into affecting safety, functional independence. The person can no longer reliably manage medications, appointments, finances, or the basic sequencing of daily tasks. They may become confused in familiar environments. They may repeat questions or conversations within minutes. Family members describe a change that is both unmistakable. At the critical B12 level, two structural processes have been generating this cognitive picture simultaneously. The oxygen deprivation of severe anemia impairing neural processing across all cognitive domains, and the accelerated hippocampal and cortical atrophy driven by sustained homocysteine elevation. The cognitive picture at this level is, in many cases, clinically indistinguishable from early Alzheimer's disease or vascular dementia. Patients' future is that B12-related cognitive impairment is potentially reversible if the deficiency is corrected before the neuronal damage crosses the threshold of irreversibility. A serum B12 in the low normal range is not sufficient to exclude this diagnosis. Methylmalonic acid and homocysteine must be measured, and in any patient with a new diagnosis of dementia, B12 functional status should be definitively established before that diagnosis is accepted. The seventh symptom is a significant mood or psychiatric disturbance, specifically a depression so severe it has produced withdrawal from life or a confusional, paranoid, or agitated state that has appeared acutely or subacutely in a person with no prior psychiatric history. At the critical level, the methylation failure has been severe enough for long enough that neurotransmitter synthesis has been substantially impaired across multiple pathways. Serotonin, dopamine, and noradrenaline production all depend on methylation reactions that require adequate B12. When those reactions have been stalled for an extended period, the neurochemical environment of the brain is profoundly disrupted. The clinical consequence ranges from a severe treatment-resistant depression to an acute confusional state with psychotic features, hallucinations, paranoid a personality change that is alarming to those around the patient. These presentations are classified in the clinical literature under the historical term megaloblastic madness, a recognition that severe B12 deficiency can produce acute psychiatric emergencies that resolve with B12 correction rather than with antipsychotic management. In any patient with a severe psychiatric presentation of unclear origin, particularly in an older adult or a person with known B12 risk factors, B12 status should be evaluated urgently and completely. The eighth symptom is a change in how the limbs feel and move that the person finds difficult to describe precisely. A stiffness, a heaviness, a resistance to movement that was not there before, combined with a weakness that seems disproportionate to the effort being made. Arms that feel leaden when raised, legs that feel as though they are being moved through resistance. A fine tremor in the hands, a clumsiness with tasks that require coordination, buttoning clothing, handling cutlery, writing. These symptoms reflect the lateral column involvement in subacute combined degeneration, the corticospinal motor tracts being demyelinated to a degree that produces upper motor neuron signs, increased muscle tone, reduced speed and precision of voluntary movement, exaggerated deep tendon reflexes. This is not muscle weakness from deconditioning or from disuse. It is the motor system malfunctioning because the pathways that drive it are structurally damaged. And at this level of involvement, the urgency of investigation and treatment is comparable to any other acute neurological emergency. The underlying cause is potentially reversible. The degree of recovery possible is directly inverse to the time allowed to pass before treatment is initiated. The practical guidance in this section begins with a premise I want to state plainly. If the symptoms I have described in Phase 4 are present, the conversation is not primarily about lifestyle optimization or dietary adjustment. It is about urgent medical assessment and clinically guided treatment. What I can give you here is the knowledge to ensure that assessment is complete, that the right questions get asked, and that the treatment, when confirmed, is proportionate to the severity of the situation. The first step is getting the right investigation urgently. In the presence of these symptoms, the clinical investigation should include a full blood count with a peripheral blood film, not just hemoglobin, but mean corpuscular volume, which will typically be elevated in megaloblastic anemia, and a blood film that will show hypersegmented neutrophils and oval macrocytes, the hematological signature of B12 or folate deficiency. Alongside this, serum B12, serum methylmalonic acid, and serum homocysteine should all be measured. As I have emphasized throughout the series, serum B12 alone is insufficient. A result in the low normal range does not exclude functional deficiency at the tissue level, and at the critical stage, the metabolic markers are the most direct evidence of what is happening inside the nervous system and the brain. A neurological examination, reflexes, vibration sense, proprioception, coordination, gait should be performed and documented. If spinal cord involvement is clinically apparent, spinal MRI should be arranged to confirm the extent of demyelination and provide a baseline for monitoring recovery. The second step is identifying the cause, because at the critical level, this is not an academic question. It determines whether the treatment is oral or injectable, whether it is a course or a lifetime commitment, and whether the underlying disease process requires management beyond B12 replacement. Pernicious anemia, the most common driver of critical B12 depletion in clinical practice, requires intrinsic factor antibody and parietal cell antibody testing. If pernicious anemia is confirmed, intramuscular B12 injections are not a treatment option to weigh against oral supplementation. They are the treatment, lifelong, because the absorption mechanism has been permanently destroyed and dietary or oral supplementation cannot compensate for its absence. In the acute phase of critical deficiency, injection therapy typically begins with an intensive schedule, daily injections for the first 1 to 2 weeks to rapidly arrest the biological damage before it compounds further. The pace of treatment at this stage is not the pace of routine supplementation. It is the pace appropriate to a system that has been running critically low for longer than it can sustain. The third step is honest expectation setting, the step that in my clinical experience is most frequently omitted in the rush to begin treatment. Recovery from critically low B12 is real and meaningful. The hematological symptoms, the anemia, the profound fatigue, the breathlessness, the pallor respond most rapidly, with hemoglobin beginning to rise within 1 to 2 weeks of adequate treatment. This is often the first thing patients notice, and it is encouraging. But it is not the full picture. Peripheral neuropathy improves in many patients over 3 to 6 months, but the degree of recovery is directly related to the duration and severity of the deficiency. And in patients who have had significant nerve damage for extended periods, residual sensory abnormality in the feet is common and sometimes permanent. Spinal cord involvement is the most variable and the most sobering. In patients treated within 6 months of neurological symptom onset, near complete recovery is achievable. In patients treated after 12 months, a situation that is regrettably more common than it should be, substantial residual deficit is the expected outcome rather than the exception. Cognitive and psychiatric symptoms follow a similar trajectory, potentially fully reversible early, incompletely reversible late. I believe patients deserve to know this honestly, not to discourage them from seeking treatment. Treatment at any stage is better than no treatment. But because understanding the relationship between timing and outcome is what gives urgency its meaning. The fourth step is removing or addressing the underlying cause, because B12 replacement without cause identification is an incomplete intervention. If pernicious anemia is confirmed, the patient also requires surveillance for gastric cancer, which is a long-term complication of autoimmune gastritis, and monitoring for other autoimmune conditions that co-occur with pernicious anemia. If long-term PPI or metformin use is driving the depletion, a medication review is appropriate, not necessarily to stop the medication, but to assess whether the indication remains valid at the current dose, and to institute formal B12 monitoring as part of ongoing management. If bariatric surgery has impaired the absorption mechanism, intramuscular supplementation is likely the only reliable route regardless of dietary intake. The fifth step is structured monitoring at 6 weeks, 3 months, and 6 months, with both laboratory reassessment and clinical neurological review at each point. Hemoglobin, B12, methylmalonic acid, and homocysteine should all be retested. Neurological examination should be repeated and documented against the baseline. Cognitive and psychiatric symptoms should be formally reassessed. And the patient's own reported symptom experience tracked specifically, not generically, should be taken seriously as data. If the methylmalonic acid and homocysteine are not normalizing within 3 months despite adequate injection therapy, the diagnosis should be revisited and the treatment reviewed. These markers are not vanity metrics, they are the most direct available evidence of whether the underlying biochemical dysfunction is being corrected. There is something I find repeatedly true in emergency medicine that I have never found a better way to articulate than this. The most preventable outcomes are the most painful to witness. Not because they are dramatic, sometimes they are not, but because they carry within them the specific weight of what could have been different, and when and how small the intervention would have been if it had happened at the right moment. I want to tell you about a patient I encountered during a night shift several years ago, a woman in her early 70s brought in by her daughter, who described a 2-year deterioration that had accelerated dramatically in the previous 3 months. The mother had been diagnosed with probable Alzheimer's disease 6 months earlier at a memory clinic. She had been placed on a cholinesterase inhibitor. She had been referred to a community dementia support service. Her daughter was in the process of arranging a care home assessment. On the night she came to us, she was confused, could not walk independently, had not eaten properly in 2 weeks because the mouth pain made eating difficult, and had a resting heart rate of 114. Her hemoglobin was 59. Her B12 was below the detection threshold of our assay. Her methylmalonic acid was critically elevated. Her homocysteine was critically elevated. She had pernicious anemia, a diagnosis that took us 48 hours to confirm with serology. She'd never had a B12 level checked at the memory clinic. It had not been part of the dementia workup protocol used by that service at that time. She spent 3 weeks in hospital. She received intensive injection therapy. When she left, she was walking with a frame. Her confusion had substantially resolved, enough that her daughter described with a mixture of relief and fury that I found completely understandable, the experience of her mother coming back. Not all the way. The balance never fully returned. There remains a residual cognitive difficulty that means she cannot live fully independently. But she is not in a care home. She is in her daughter's house. She knows where she is. She knows who her daughter is. She reads. She watches television and follows the plot. She has opinions about things. That outcome is better than the trajectory she was on. It is not as good as the outcome she would have had if someone had checked a B12 level 2 years earlier. The gap between those two outcomes is the cost of the misdiagnosis. And the question that her daughter asked me at the discharge meeting, quietly, without accusation, but with a weight I have never forgotten, was, how common is this? The honest answer is more common than it should be. Research published in the British Medical Journal has estimated that B12 deficiency affects up to 15% of adults over 60, the substantial majority of them undiagnosed. Among patients in memory clinics, the prevalence of occult B12 deficiency is higher still. The systematic exclusion of B12 as a reversible cause of cognitive decline before a neurodegenerative diagnosis is accepted is not universal practice. It should be. And until it is, the most reliable safeguard is a person who understands these 8 symptoms well enough to ask the question themselves. The 8 symptoms I have described in this video